regarding, let me just remove this. First of all, guys, a little bit about me. My name is Dr. Alaa. I'll be teaching you the 12 days, the whole course, and I'm basically a certified teacher and teaching clinical fellow in the NHS. So my main job during the classes is to ensure that I'm going to try my best to give you the best ways to pass PLAB 2, and of course to understand what they want exactly to see in the exam. Okay, of course, in the GMC, they want to see something in your personality, in your performance that you have to be aware about, and therefore, of course, you have to perform in that way, and at that time should be able to pass from the first time, inshallah. So if we speak, guys, generally, first of all, what do you expect from me in the classes? First of all, we have 12 days classes. They are 15 days overall, but basically we have 12 days teaching, okay? So we're going to take 3 days, 1 day off, 3 days, 1 day off, 2 days, then 4 days, 4 days after each other. Why? Because we don't work basically, or we're not going to work on Sundays because we are struggling somehow to work on Sundays. I think you understand how it's going in this country, okay? So Sundays are somehow, don't touch. Okay, so basically, we're going to take it in that way. 3 days, then 1 day off, 3 days, 1 day off, then 2 days, 1 day off, then 4 days after each other. Okay, I think they send you the schedule in the group, right? Okay, so that's for this one. The second thing is what we're going to do during the classes. We're starting every day from 9:30 up to 7. We're going to take 1 lunch break, which is fixed every day from 2 to 3 p.m. Some days you might take it at 1:30 or 2:30. It's okay around that time, okay? So we'll take 1 hour for the lunch break, and then we will take in the morning 15 minutes around 12 or 11:30. And we'll take, of course, at the end of the day, maybe at 5 or 5:30, another 15 minutes, okay? So that's how it will go. And I'll be the one who's giving you the breaks, which means like don't request for it, okay? I'll be giving you the breaks when I feel that you are completely saturated, okay? So that's for the breaks during the days. What else you are having in your package? You are having access to the practice area outside. So here, guys, we're doing the classes. And in the classes, we will teach you everything. Like we teach you the SIMMANs, prescriptions, everything which is done outside, okay? But outside, they're repeating the stuff for you. What do I mean? Outside every day in the practice area, mannequins, basically, we'll talk about that. Outside every day, we're teaching you the teaching scenarios, procedures, and combined stations. We'll talk about that. Just you will hear the names now, but you'll understand what are those stuff. Combined stations and teaching and procedures are done outside every day, except Sundays. Sundays we are off, okay? Every Wednesday, we have SIMMAN class going on from 10 till 7. And every Friday, we have prescription class going on from 10 till 7. Every day, of course, we're teaching from 10 till 7 outside in the practice area. Okay? So therefore, why I'm doing that, we'll understand later when I give you the curriculum of the exam or how it's going, because you will understand at that time how or to what extent basically those parts are quite important. That's why we're fixing them every day outside, okay? Because they are essential part of the exam. You must give them in the exam, okay? Therefore, every Friday, prescriptions are done. Every Wednesday, SIMMANs are done. And every day, except, of course, Sunday or Wednesday or Friday, we are having teaching, procedures, and combined stations, okay? From 10 till 7. What else do you have in your package? You have 2 MOOCs or 3 MOOCs according to your package, of course. The 2 MOOCs or the 3 MOOCs, those are, I would say, the golden thing in your package, of course, after my teaching, okay? So basically, what do we have in those MOOCs? In those MOOCs, guys, you are having 16 stations inside, typically like the GMC. I always say the MOOC area is typically like square. I think you're aware about square and street, okay? So MOOC area is typically like square and street is where you're going to take the exam. Hardman Square, Hardman Street, the GMC, okay? So the square is typically like the MOOC areas, like small rooms, small corridor, everything is typically like the MOOC area. The street is somehow bigger than this, okay? Guys, basically the street and the square are the GMC buildings, center, of course, of Manchester. Those are basically, in the beginning, GMC was only square, like the square, like the MOOC area, okay? But after basically COVID-19, they opened the street because, you know, the distance and the stuff, okay? So therefore, the street is somehow bigger place, okay? So the MOOC is basically you're having 2 MOOCs or 3 MOOCs. You are having typically like the GMC 16 stations. Each and every station is 7 minutes, sorry, and 1 minute to read outside the cubicle. We'll understand that more and more. However, the MOOCs, and this is what I always say, let's speak about that, will let you exactly understand where you are. Like, what did you do good? What did you do in a good and not in a good way? Do you get the idea? The MOOCs, you're going to go for the stations after each other, like typically like the exam. After you finish them, you will go outside and then you sit down for 5 minutes. Then they will take you back inside for the feedback. Okay, so you finish the MOOCs, you finish the exam. Then they will take you inside again to go for the feedback one by one. And you will sit down with each and every examiner for 3 or 2 minutes to take your feedback. It will be oral feedback, like they will speak to you. They speak to you, what did you do wrong? What did you do right? And then after that, after you leave, of course, the MOOC area, at that time, they would send you everything, of course, in your in your email. You receive it in your email. Okay, so you will receive it orally, verbally, and also written. Do you get the idea? The main reason I am putting this oral feedback or verbal feedback after the mocks is because I believe some stuff should be said, not written. Do you get the idea? For example, your body language. How do you speak? Your IPS. How do you project your information? How do you show the empathy? How do you change your facial expressions or your tone? Do you get what I mean? Okay, so some stuff must be said to you, and always, this is what I receive from the candidates, of course. You remember what they told you in the exam, so you work on it. Do you get what I mean? That's for the mock. So the feedback loop will take around 1 hour, and the mock will be around 2.5 hours. 2.5 hours, yeah. Do you get what I mean? So that's for the mocks. Regarding the mocks, you're going to ask, how should I book the mocks and stuff? Of course, before I used to book the mocks for you and choose for you the dates, not anymore. Now I'm giving you the chance to do that on your own. So when you're going to attend the sessions and finish everything in sessions, or even after 1 week or 9 days of the sessions, you will understand exactly when do you want the mocks, especially people who are having exams soon, okay? So at that time, they will send you a link to book your 2 mocks or 3 mocks accordingly, okay? So I'm allowing you to choose the dates of the mocks for one reason, which is basically, I have 3 types of candidates, okay? The first candidate, they will say, I want to book 1 mock early, 1 mock late. Some people like this, they will say, I want to book 1 mock early, like 1 month before my exam, to understand where I am exactly, so I can work on it. So then I will book 1 late, close to the exam. Other type of candidates, they will say, no, I want to book the 2 mocks very late, close to the exam, because I want to be fully ready. Like, I want to be completely ready for everything, okay? Other than this, some people say, I want to book the 2 mocks early, because I don't want to go anything close to it will make me panic. I don't want to go for anything close to my exam. That's why it's completely your choice, according to your personality. Understand what is your personality. Accordingly, you can book. You can book 1 early, 1 late, 2 late, 2 early. It's up to you, completely up to you. You know what I mean? That's for the mocks. And of course, all the examiners are doctors. And of course, some of them already are working in the NHS. Some of them, are, of course, are GMC certified. So that's for the mocks and for the package. Regarding the notes, of course, I will send you the notes already in the groups after we finish all the days. Sometimes I might send it after each and every 3 days. So we finish the 3 days, and I will send it in the day off. 3 days, then I will send it in the day off, okay? But I will advise you to please try to write. Why try to write? Because, guys, everything in the GMC is every day updated, like changing. They get the idea. I'm not speaking about the guidelines. Guidelines are the same. But I mean, the scenarios, what's happening inside the GMC is every day changing somehow, every week almost changing. They get the idea. So we are getting what's happening in the GMC. So I want you to get what's happening exactly in the GMC, like in details. You know what I mean? That's why I advise you to always to write, try to write, always write. If you write the stuff, you will get what is happening till literally your exam. Like you will know what's happening till your exam, so that you will be more and more updated. So the exam will be simple for you. Do you get what I mean? Okay. So that's for the notes, and already I will send you the notes. And regarding the classes, after tomorrow it will be published on the website. The recorded classes, I will say it right now. The classes that will be on the website will be previous classes. Your current batch will not be recorded. Your current batch is for you. Like this is live batch for you to attend. Do you get what I mean? So what's recorded on the website is something happened previously, like from 2 months or 3 months, 2 months, okay? But basically, your current batch at the moment, that's for you. That's your live classes, because I'm a really big fan of the live classes. I don't prefer the recorded classes at all. By the way, even I didn't prefer to put it before, but I'm putting it after your request. Some people requested for recorded classes because they can't attend. But I will always prefer you to attend live classes, because nothing compared to this. Like you can ask your questions, you can listen, you can ensure that you are getting everything. Do you get the idea? Better than just opening something and just keep listening. Okay, that's for the classes. What else? Anything which is covered outside in the practice area will be covered already here in the class, as I told you. And of course, outside it's repeated. So if you wish to attend again and again, to keep repeating, because this exam is all about repetition. So guys, before I proceed, you understand now the approach? This is, by the way, the approach I gave you. As I told you, is the approach of this is the approach at the end, as we agreed. I told you what the approach is for what? For the first presentation patient. Because someone is coming and saying, Doctor, I have chest pain. It's not follow-up. It's not follow-up approach till now. And it's not even second look. This is first presentation one. Like I have chest pain, I have headaches, I have back pain. First presentation, first time you are seeing him. That's your approach. As we agreed about the intro, history, persistent complaint, then the DDs and risk factors and red flags, then the fixed beam of TOSA, then the eyes, effect of the symptoms, then go and examine your patient and diagnose and treat. Any question regarding the approach or any question regarding this then now? Are you on the same page? Okay. Now we'll talk about what? We'll talk about chest pain. Of course, guys, the first thing we'll start with is the pains, like headaches, chest pain, back pain, and so on. because this somehow will let you know or understand how the stuff are coming, and of course also they are quite common, to be honest. So that's why we'll talk about them. First of all, guys, we'll talk about chest pain. Chest pain in PLAB 2. What are the cases that we have chest pain in PLAB 2? We do have MI, and by the way, MI, we are having 2 cases, and the 2 cases for a reason. Do you get the idea now, guys? I just want to say something. How do we get to know, for example, those cases? From you, like one day you'll be source of this material. Do you get the idea how when you go to the exam and finish the exam? So we'll ask you, what do you see inside? Do you get the idea? Okay. So basically, I just won't say that. Why? Because what I'm telling you right now, you have to follow. Okay, like this what's happening in the exam is I will tell you even what they will say inside to you exactly. Do you get the idea? The thing that you have to learn, by the way, you might feel, okay, it's easy now, it's simple because I will know what to see inside. No. Knowing what you will see inside is not the main thing that you have to know. The main thing is I have to know how to talk inside. Do you get the idea? Because even you will know it's MI, you will know it's shingles, you will know everything. But to remember what to say and to multitask inside and listen and talk and think and show the IPS is somehow challenging. So this is what I have to learn. So all the stuff you will know, and I promise by the end of the course, you will know almost, if we have, for example, in PLAB 2, 450 topics, you will know 400 of them. 50 will be miscellaneous topics all over the place. Okay, and you will make the mind maps and everything. But it's not about knowing it. It's about how you are saying it. So this is what you have to learn. Okay, so how we're going to start, of course, with the medical part. We will talk about the approach, how that's what we're going to study with each other. So we'll talk about the approach of the chest pain. Then we'll take them one by one. When we take them one by one, how we are going to write them, it's what clinchers and management. Do you get the idea? So why? Because this will make it easy for you to remember. So for example, in the shingles, I will have rash. Done. And you have to remember, in the shingles, I will have rash, and I will have 70 years old one. Why? Because they won't teach you the idea of what vaccinations. So I have to wake up inside. I have to know that when I find shingles case and 70 years old male inside, I have to tell him after finishing the treatment, a cyclovir and stuff, come back to us because you have to take vaccination because there's risk of recurrence. You get the idea? Same for this musculoskeletal pain. This musculoskeletal pain, this case, guys, let me ask you a question. Musculoskeletal pain in overall, what is the treatment of it? Painkillers, self-limiting. So mainly what? NSAIDs. They get painkillers. Of course, the choice is NSAIDs because inflammation and so on. Correct? Okay. What is happening in PLAB 2? In PLAB 2, the musculoskeletal pain patient, he will be suffering from what? Von Willebrand disease. What is this? Bleeding disorder, X. So can I offer him NSAIDs? I can't. So what's the choice? Paracetamol, excellent. And if we didn't improve the paracetamol, I will offer what? Cocodamol. Cocodamol is equal what? Paracetamol and codeine. But I don't touch this NSAIDs because it can cause more and more bleeding and so on. Do you get the idea? So if you don't know this, I just want to say, if you don't know this is existing, you will end up saying to this patient, take NSAIDs, ibuprofen. And I'm afraid if you say to him NSAIDs, you are failing it, simply. Why are you failing it? Because his life is at risk. This is that you are not safe at that time because he can have a bleeding and stuff. Do you get what I mean? So this is the aim of PLAB 2 stuff. The PLAB 2, the main thing is to get what they want to deliver in each and every case. They want to deliver you a message. You have to get it. That's number one. Number two is how to speak now, how to deliver my information, how to deliver my knowledge. Do you get the idea? That's the main thing. If you have those two, you'll be fine in the exam. You'll be completely fine in the exam. Do you get the idea? So unfortunately, and they will say it in that way, you must remember the cases. I do understand it will be difficult, overwhelming, but this is the only way to pass PLAB 2, simply. If you go to the exam with a general approach and you go and yeah, I will remember, I will know, no, you will not. And even if you know, you will forget something that they want to do in the past. For example, like this one. You might forget to ask about past medical history, right? If you forget here, you are done. For example, do you get the idea? In this shingles, if you don't ask about rash, you are done. You will not know either it's shingles, and that's it, we are done now. Do you get what I mean? That's why, that's what I told you yesterday, that you must know the cases and try to remember them. Of course, my main job is to help you to remember them, of course, in a very nice and simple way. However, the key is repetition. Never ever think, if you read them once, you will remember. Never think about this. Okay? When you're going to remember, at least reading them twice. At least. Ideally, perfectly thrice. So I have, for example, I'm not saying, by the way, practice, I'm saying reading them. like knowing, for example, we have chest pain in PLAB 2, which are 7 cases or whatever. Those are the cases. In the MI, I do have this patient. In the shingles, I do have 70 years old. And this musculoskeletal pain patient is having bleeding disorder, so I have to offer paracetamol. That's what you have to remember. If you know this, thank you so much. Go to the exam and talk. That's it. Do you get the idea? Again, how it will happen, how it will become easy for you? Repetition. The more you repeat, the more you go through the cases more and more, the more you remember. The less you repeat, the less you will remember, and the more you struggle inside the station. Do you get the idea? Okay. It will be overwhelming in the beginning, but at the end, it will make sense. Everything will make sense because you can make the mind maps at the end. Are you getting me? So take it easy, take it slowly. Now let's just start with chest pain. Are we on the same page? Good. Okay, let's start with this one. Chest pain approach. First of all, chest pain is something very common in PLAB 2. It's almost happening every week. You must have chest pain case in the week, like at least twice or thrice. Okay, any of them can come. And the commonest between all of them is shingles. That's number one. Okay, however, when I talk about chest pain, why people are feeling it easily? Because in the chest pain, we are having what we call the reversed approach. I will talk about this now. It's textbook. It's not something we are creating. It's textbook. What is the reversed approach? They are saying to you, basically, they want to deliver to you two messages. What is the first message? Any patient who is suffering from chest pain, for us, I mean adult or old age, whatever, like from adult and so on, is suffering from chest pain. For us, they are MI until otherwise. Do you get the idea? Any patient I see either in the GP, in the A&E, telephone call, I don't care. Any patient I see chest pain, for me, he is an MI until proven otherwise. Do you get the idea? Therefore, in the beginning, when I see chest pain, I have to target what? MI. If I don't find MI at that time, I will search for other stuff, no problem. Do you get the idea? That's the first concept you have to know. That's number one. Number two, any patient coming to the emergency department, secondary care, hospital, with chest pain, regardless what you are thinking about, even if you told you it's a trauma, it's fall, like, you know, it's musculoskeletal pain, I must do for them cardiac enzymes and ECG before they leave the hospital. I cannot discharge them home without seeing normal ECG and normal cardiac enzymes. If I discharge them before confirming those are both normal, I am at risk because patient safety is at risk. Simply, even if they are telling you even if they told you I have rash, like they are shingles, I don't care. It could be shingles on top of MI. Do you get the idea? So any chest pain coming to the, and so I'm not speaking about GP, I'm saying A&E. Chest pain coming to the A&E, I cannot discharge them home until I'm going to do for them cardiac enzymes and full leads ECG and document down that they are normal, then they can leave the hospital. Are we on the same page? Okay. How about chest pain coming to the primary care, GP? Do I have to refer them to the hospital immediately? Okay. Any other options? Chest pain coming to the GP. Do I have to refer them to the hospital immediately or not? No. GP is different now. GP, I am what? The filter, I told you. The GP is the main filter. If he is MI, unstable angina, of course, hospital immediately. Thank you. And I'm speaking symptoms-wise now, okay? If he is not, he is pain, he is whatever, at that time, I treat and discharge home. Thank you. Do you get the idea? And that's why I'm telling you, the primary care in the UK is completely different from secondary care. Secondary care are having their own protocols. Primary care have their own protocols. Do you get the idea? Are we on the same page now? Okay. So now let's understand more about chest pain approach. How we're going to start. Knock the door and go inside. You'll find the patient and the examiner. Greet the examiner. Hello, or good afternoon, or good morning. There's no hi. My name is whatever. James number is whatever. Thank you. Go and have a seat. Now you will see different stuff. They might, I told you, the pericarditis, he'd be like doing like this. He'd be putting his hand in that way and leaning forward in that way. Because he's feeling this is helping him. Okay, this pericarditis. MI, he will be, for example, holding, let's assume this is tissue. He'll be holding a tissue. He'll be holding the left shoulder in that way. And sometimes he'll be holding the chest at the same time. Like in that way, be like sweating. He'll be holding this. By the way, he will not be dying. I just want to say, like he's acting. Because some people also will think he's now dying. No. He's just acting to give you the vibes. Do you get the idea? Because when you see someone like coming to the emergency in that way, this holding this and this, for me, it's MI, literally MI. There's no otherwise, MI. Do you get the idea? So he'll be acting in that way. He'll be holding this and putting this in that way. And sometimes, of course, he'll be sweating and stuff. Okay? Regarding the shingles, he might just be doing this here. And of course, when you're going to ask him about the chest pain, he said to you, doctor, I have chest pain, and I'm having it here. You know what he'll move with? Dermatome. You know the dermatome? He'll say to you, this, it's here. Do you get the idea? Musculoskeletal pain, he might be holding the chest. Guys, why I'm saying all of that? Because I don't care about what they are doing. For me, all of them are MI until otherwise. Even if I go inside and he's like this, I don't care. For me, he's MI until otherwise, as long as complaint is chest pain. Do we get the idea? Good? Okay. Now, so I knock the door, I go inside, I go and sit down. Start. Of course, if the patient is short, I told you, copy your patient. If the patient is sitting like this and stuff, sit down where edge of the chair in that way and lean forward. So that I show I'm worried about you. I'll start now. So hello. Now, if he is showing concern and he is distressed and stuff, no smile. Make your face serious. If he is okay, smile, no problem. So hello. This is Dr. Whoever, one doctor in this A&E or GP, whatever you are. Are you John Smith? Yes, I am. Is it okay to call you John? Yes. Can I please confirm your age, doctor? Yeah, I'm 60 years old. Okay, Jane, thank you for confirming. So I understand that you came because you are having some chest pain. Am I right? Yes, doctor. What do I do? So you have to what after confirming everything? Paraphrase. And you will always know from outside the cubicle, patient coming with chest pain. You know what's your task in this chest pain? It will be something, I don't know if I'm having it here. Yeah, something, can you see this one? That's it. It will be like concerns or chest pain, any of them. If I have, let's just leave this one. If I have like this one, how I'm going to paraphrase. Okay, I'm one of the doctors in this A&E or GP, whatever you are. Are you John Smith? Is it okay to call you John? Can I please confirm your age? I understand you came because you have some concerns. How can I help you? I always paraphrase. Always paraphrase. Do you get the idea? So I understand, John, that you came today because you have some concerns. How can I help you now, doctor? Yeah, I have chest pain, doctor. Okay, I'm sorry about that, and I'm here to help you. So what did I say to you before? How we are going to start the history? Like, wow. How are you going to start your history? Chest pain. Excellent. Tell me more. That's number one question. So anyone presented complaint? Okay, can you please tell me more about it? That's number one. Now, what they expect will happen in the exam? What they would say? Now, guys, we're applying the approach. Do you get the idea? Okay. Now, what will happen in the exam? What do you think they will say to you? Doctor, what do you want to know? Or doctor, like what? Don't think they will answer everything. No. They will always be annoying because they want to hear the questions from you. Doctor, like what? What do you want to know? So what I will do, the first question now. What is the first question since when? Excellent. But will I start with this in the chest pain? No. And that's why it's called what? Reverse approach. Because I will start with what? I will start with the most important question, which is, do you have the chest pain right now or not? That's number one. This is what's making this approach unique. They get the idea. So now I start. So Mr. Johnson, can you please tell me more first of all? Doctor, what do you want to know? Like what? Okay, Mr. Johnson, can I kindly confirm? Do you have this chest pain right now, Mr. Johnson? Now, let me guys look at the cases with you. What do you think they will say? All of them. Yes, excellent. The only one that might say to you no in the exam is this one. Stable angina. That's the only one because now he is resting and is relieved with the rest. Do you get the idea? The rest, all of them will say, yes, I'm having it right now. The pain, of course, pericarditis, yes, it's ongoing pain, correct? MI, yes, PE, yes, shingles, yes. Do you get the idea? So what he will do next, okay, if the patient has chest pain right now, what does that mean? It is MI until otherwise. So what I will do right now, will I go down normally for the other stuff, which is Socrates and stuff? No. We have something which is called what, as I told you? This reverse approach, which is what, guys? Number one is I go after the MI until I exclude it. What does that mean? We have basically what we call the 6 criteria of the MI, which is in front of you. The SCR and the 3S. What are those? By the way, SCR is part of Socrates. Site, character, radiation. Excellent. And I will add what now more? Since when? Why since when I will add it? Because sometimes it can help me with the treatment. He might go for PCI, he might go for whatever. I don't know now how many hours he's having the pain right now. Of course, the more hours it is, the more risk we are in because the heart is dying. Okay, so, and what about the 3S? Shortness of breath, sweating, sickness, nausea and vomiting. Shortness of breath, sweating, and sickness. Now let's apply it. So I will start, okay, I'm one of the doctors in this GP surgery. Are you, whatever, is it okay to call you, whatever, can I please confirm your age? So I understand you came today because you have some chest pain, am I right? Or I understand you have some concerns, am I right? Yes, doctor, how can I help? Doctor, yeah, today I came because I have chest pain. Okay, Mr. Johnson, I'm sorry about that. I'm here to help you. However, can you tell me more about this pain, please? Doctor, what do you want to know? Okay, can I kindly ask you first of all, do you have the chest pain right now, Mr. Johnson? Yes, doctor, I'm having it. And if I can ask you, please, since when you have this pain exactly? Doctor, yeah, 3 hours ago. Always the MI will be something very acute. 2 hours ago, 30 minutes ago, 3 hours ago. This is what would be in the exam. I'll tell you, of course, what they say in the exam. Okay, and where is exactly the pain, Mr. Johnson? Can you point with your finger, with your hand? Where's the pain exactly? Doctor, yeah, it's here. And they will always, what is the MI factor or stuff? It is central crushing chest pain going to the left side. Central crushing chest pain going, by the way, I'm saying left side, left shoulder, left neck, left jaw, any part here. I don't care where it's exactly. But the commonest, of course, is the shoulder. Do you get the idea? Because it's the heart. So I will ask now, can I kindly ask you since when you have this pain exactly, doctor? And ask exactly, because I need to know, because the 1 hour will matter for me in the treatment, in the PCI and stuff. When exactly, doctor? Yeah, it just happened 2 hours ago. Okay, and can you tell me where is the pain exactly, Mr. Johnson? Can you point with your finger, with your hand, doctor? Yeah, it's here. Do I now follow this when he's saying that? No, I have to confirm. I'm going after MI. So, Mr. Johnson, is it central chest pain? Yes, doctor. I confirm, and I have to hear it. Even he will say to you, doctor, it's here. Yeah, here, I don't care. Maybe his hand is big. I don't care. So I will ask him, is it central chest pain, Mr. Johnson? Yes, doctor. I'm now going after the MI slowly. Okay, and can I kindly ask, can you describe for me the pain? Doctor, yeah, I'm not sure. It's just severe pain. Okay, Mr. Johnson, can you describe it as central crushing chest pain, Mr. Johnson? Yes, doctor. So first of all, I give him a very small chance to answer. If he didn't answer, I am targeting the MI. So Mr. Johnson, can you describe this pain as central crushing chest pain, Mr. Johnson? Yes, doctor. Okay, and do you feel it's going anywhere? Your left side, left neck, left jaw, anywhere in this left side? Doctor, yeah, it's going here, my left shoulder. Okay, can I kindly ask you, please, apart from the chest pain, how about you breathing? Any shortness of breath? They will not in the exam, by the way, guys. They will not in the exam be like, they will not be like this. This is the same man. He'll be dying. But they will be what in the exam? They will be, you say to you, doctor, yeah, discomfort in the chest is I'm not breathing well. It's not the same like before. Do you get the idea? Okay. And do you feel that you are sweating? Yes, doctor, I am. How about, do you feel sick? By the way, nausea and vomiting are different, two different things. Do you feel sick? Yes, doctor, I'm feeling sick. Did you vomit by any chance? No, doctor. I'm done. Okay, from this SCR and the 3S, did I suspect MI or not? Yes, he's telling you what it's central conscious pain going to the left shoulder, and he's feeling sick, but he didn't vomit. He's sweating as well, and discomfort in the chest. I mean, my shortness of breath. So what I will do now, can I carry on normally like any other patient? Never ever. I must pause, and that's why it's called what's reversed. I will speak about this now. I have to pause and take any single initial management or measure that will be saving my patient life, which is what? Aspirin, exit. Now, this aspirin for me is not a lifesaver. It will save his life or he will die, simply, in a very simple way. That's why aspirin, by the way, guys, in the UK, it's essential part of the first aid bag. This aspirin, by the way, in the UK is over the counter, 75 mg over the counter. because of that, because of this MI, because of the stroke and stuff. Particularly MI, of course, because the stroke you don't know it's hemorrhagic or ischemic or whatever. But for the MI, this aspirin is over the counter because of that. Because anyone who is having any suspecting heart and they are trying to raise the awareness, when you feel that you're having chest pain, going to the left shoulder, whatever, take aspirin. Of course, the over the counter that we have in the UK is what? 75, the prophylactic dose. So how much they have to take? 4 tablets, 300 mg. So what you'll do? Now you accept pain. You will pause. Wait now. I have to pause because I have to take a serious action now. Okay, Mr. Johnson. So listen to me very well. Just listen how I'm going to do it. So, okay, Mr. Johnson, thank you for answering the questions. However, from what we have discussed so far, we are worried about you. This is the warning shot. You know the warning shot? You don't jump because patient will die from the shock. They get the idea? You start one by one. So, Mr. Johnson, from what we have discussed so far, we're worried about you. And the reason why we are worried is because you mentioned you're having chest pain, central, crushing, going to the left shoulder. Also, you are having shortness of breath and you are sweating. So we are afraid this pain could be coming from the heart. Therefore, we would like to offer you aspirin, which will be 300 mg without any delay. And I'll be asking the nurses to perform an ECG as soon as possible. Meanwhile, I carry on my assessment. By the way, I didn't look at the examiner. I don't look anywhere because some people look at the examiner, of course, and say, offer aspirin, please. They get the idea. I didn't do anything. You know, like talk to yourself in the exam. Do you get the idea? Because that's what we do in real life. I can never, ever, suspected MI, I can never, ever carry on 1 single second more without offering aspirin. Because I told you aspirin here is not like painkillers, because some people speak about the painkillers. How about the painkillers and stuff we spoke about yesterday? No, this is completely different now. This is lifesaver. It's not because of pain. This will kill my patient or save his life. Do you get the idea? So anyone which I suspect MI is going on, first of all, I have chest pain in front of me, I have to go after MI. As soon as I'm suspecting it, I have to pause and offer aspirin. After the aspirin, now carry on normally. By the way, you ask for the rest. Okay, tell me more about, and you carry on. Listen to me again. I will do it from the beginning, okay? Listen to me very well. Don't try, listen to me. You will start, as I told you, knock the door and go inside. Read the examiner. Go and sit down. Hello, this is Dr. Alaa in this department. Are you Jonah Smith? Is it okay to call you John? Can I please confirm your age? So, John, I understand that you came today because you're having some chest pain. Am I right? Yes, doctor. Okay, I'm sorry about that. I'm here to help you. However, can you please tell me more about this pain, please? Doctor, what do you want to know? Okay, John, can I kindly ask you first of all, do you have this chest pain right now? Yes, doctor, I'm having it. Okay, and can I ask you when exactly the pain started? Doctor, yeah, 3 hours ago. And can you tell me, Mr. Johnson, where is the pain exactly in the chest? Can you point with your finger, with your hand? Doctor, yeah, it's here. Okay, so do you feel this is central chest pain? Yes, doctor, it is. Okay, and can you describe for me the pain, please? You know, how do you feel the pain is looking like? Doctor, I don't know, just pain. Okay, can you describe this pain as central crushing chest pain, Mr. Johnson? Yes, doctor, it is. Okay, is it going, for example, to the left side? I mean, left shoulder, neck, jaw, anything like that? Doctor, yeah, it's going here to my left shoulder. I see. Now let me please ask, apart from the pain, how about your breathing? Any source of breath? Doctor, to be honest, yeah, discomfort. I feel discomfort on my chest. Do you feel sick? No, doctor, I'm not feeling sick. Okay, how about sweating? Do you feel that you are sweating? Doctor, yeah, I'm sweating. To be honest, something is going on wrong with me. Okay, I'm sorry about that. However, Mr. Johnson, thank you for answering this. And I'm afraid from what we have discussed so far, we're worried about you. And the reason why we're worried is because, unfortunately, you mentioned the chest pain is central, crushing, going to the left shoulder. And also you are sweating. You're also feeling that the breathing is affected. So I'm afraid, Mr. Johnson, this pain could be coming from the heart. Therefore, without any delay, I would like to offer you aspirin, which will be 300 mg. You will take it immediately. And they'll be asking the staff or the nurses to perform ECG, which is a heart tracing, as soon as possible. Meanwhile, Mr. Johnson, I will carry on my assessment and ask you more questions. Is that okay for you? Yes, doctor. Can you please tell me more about the pain, please, now? This pain, anything is helping you with this pain by any chance? You know what I'm carrying on now? The rest of the Socrates. I ask about the SCR, the rest of it, onset, improving, getting worse, scale, ask about the rest now. But what I did at the moment is what I saved my patient's life. Thank you. He is now safe. If it's MI, you saved him. If it's not MI, you didn't kill him. Thank you. Are we on the same page? Are you there? Okay. Any question online? Okay. So now we will carry on. I will carry on, by the way, literally. What I will carry on with? The rest of the Socrates. What do I have the rest of the Socrates now? Onset, anything is helping you with the pain, anything is making it worse, and scale. That's what we are missing here, correct? So ask. So can I kindly ask first of all, how this pain started, Mr. Johnson? Do you get what I mean? So you will pause and speak. Write down this. Okay, Mr. Jones, thank you for answering my questions. And from what we have discussed, we are worried about you. That's your warning shot always for any patient. We're worried about you. After saying we're worried about you, you have to prepare him, preparing him mentally. How to prepare him mentally? Tell the story. The reason why we're worried about you is because you mentioned it's central, crushing chest pain, going to the left shoulder, and also you are sweating, you are feeling sick, you are having shortness of breath. So unfortunately, Mr. Johnson, we are worried this pain could be coming from your heart, from the heart. Do you get how to speak? Okay. See what I said? I said we are worried this pain could be coming from the heart, because what do you do in the exam? Some people say, well, worried this could be a heart attack. Now, if you say this, enjoy. Do you get that? Because now you say to you, doctor, do you mean I have a heart attack? Do you mean I will die now? Now enjoy there. Do you get the idea? So I never speak like this. I never talk like this. I always speak. I told you, always be, guys, indirect. I told you this since yesterday. Indirect language. Always, I will describe this as toxic. Being toxic? Be toxic. What the meaning of toxic? Indirect. No one can even catch a mistake. Be toxic in the exam, in the real life, in the medicine career. Because once you say something which is 100%, or you are saying something which is quite clear, mistake can happen. So always indirect language, always indirect language, always. So I don't say to the patient heart attack, but I will say to him what the pain could be coming from the heart. So he will get to know there's something serious, but he will not be panicking because he didn't see the heart attack yet. By the way, I will say to him heart attack, but later, not now. Do you get what I mean? Okay? So I speak from what we have discussed, we're worried about you. The reason why we are worried is because you mentioned that you are having, tell the story, talk about the story now. You are preparing him for something wrong coming on. So you are having chest pain, going to the left shoulder, center crushing. You're also sweating and sick. Unfortunately, Mr. Johnson, and while you are talking, add the 3 words. Unfortunately, I am sorry, I am afraid. Always those are your supporters in the exam. Okay? So unfortunately, Mr. Johnson, we are worried this pain could be coming from the heart. Therefore, and say this sentence, without any delay. Therefore, Mr. Johnson, without any delay, we would like to offer you aspirin and speak about the dose, which will be 300 mg. And I'll be asking the nurses to perform ECG, which is a heart tracing, as soon as possible. We're worried about you. The reason why we're worried is blah, 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 tell the whole story. So therefore, I would like to offer you aspirin, which without any delay, we would like to offer you aspirin 300 mg. And they'll be asking the nurses to perform an ECG, which is a heart tracing, as soon as possible. Meanwhile, Mr. Johnson, I will carry on my assessment. And by the way, don't pause, even don't stop, don't look around, don't do anything. Patient, by the way, even will be like, okay, doctor, go ahead. Do you know what I mean? Meanwhile, I carry on my assessment. Now, what will happen? The patient will speak now. Okay, doctor, okay, no problem. Go ahead, carry on. Ask about what? Onset? Anything is helping you? Ask about the pain now. Okay, Mr. Johnson, tell me more about the pain first of all. How did it start this morning? How did it start 3 hours ago? Doctor, just all of a sudden. And anything is helping you with the pain? Doctor, not at all. Anything is making it worse? Doctor, I just think it's getting worse. That's it. Can you scale your pain from 1 to 10, as 1 is the least and 10 is the maximum? Doctor, yeah, to be honest, 3 hours ago, I felt it's almost 8 or 9. Now I feel it's 6 or 5. Now you will have a question mark, right? Why you will have the question mark? All of you will ask. The pain of the heart attack should be getting worse, right? Is that correct? Okay. So what do you think what he mentioned right now? So it's not heart attack? It's not, or it is, or what? It is not. Why? No, no. Any other options? Huh? Net progressive, yeah. Guys, let me say something and put it in your head, okay? In medicine overall, we are having 3 conditions in which we always say when the patient is having pain, not only, I will speak about 2 now, 3 later. 2 conditions, remember them. When we say the pain is a blessing, when the pain is a blessing, in the MI and in the otitis media. Let me explain more. The perfect patient for us when we are waiting in the emergency, for example, is someone who is coming and we are on the peak of the pain. Like they will say to you, doctor, it's 10. It's not even falling on the scale. It's 11 out of 10. That's our perfect patient. Why? If the patient is getting less as the time is passing, this means what's happening? Heart is dying. Ischemia. Do you get the idea? So, and by the way, which is quite famous about heart attacks, if the patient coming after 3 hours, 4 hours, 12 hours, always make sure that you find part of the heart already. If you go in angiography, you find part of the heart already ischemic. Thank you, done, dead. Because no heart attack can survive for 12 hours or 3 hours, right? Thank you. Do you get the idea? So the pain in those people literally is a blessing. Because when he comes to you to the emergency, he'll be like, and he's holding the chest and this, and he's literally dying right now. Like the pain is 10 out of 10. This is the perfect one. Because when you go inside, you'll find the heart is quite like alive. The heart is still the heart is there. The heart is still vital. But if I go inside and the patient is saying, Dr. Yeah, it was 10, now it's 6, it's 5. Now make sure that ischemia is happening. Thank you. Because the pain when it's happening with the full heart, different from half heart. Or 75% of the heart. Do you get what I mean? Same for the otitis media. The perfect child for us is the child who is coming and the mother is saying he's screaming, he is shouting, he is crying. This means this is perfect otitis media. When the mother can't say to you, my child was crying for almost 10 days or 8 days, and now he stopped crying, he's not crying anymore. What does that mean? Perforation has happened. Exit. So the pain is a blessing. Do you get what I mean? Always remember in that way. So those people, when they can't say this is not a good, this is the worst flag like ever when we don't want to hear it, because when he say that I'm improving, this means that he is dying simply. You know this before death. Do you get the idea? Okay. So that's why, of course, they gave you this in the exam, because all of you will be confused. But in fact, this is very characteristic about MI when they come late, like late presentation. That the patient will have what patient will say in the beginning the pain was almost 10 out of 10. Now it's 7 or 6 or something. So as long as the pain is becoming less, this means ischemia is happening more and more in the heart now, in which you have to intervene as soon as possible. You get what I mean? Good, okay. So we ask about the scale, we're done with the scale. What we go for now? DDs. Now you ask about the MI, done already. Do I have to ask about this stuff? Of course, 100%. Not, by the way, some of you would think about real life. In real life, we'll not ask about any other DDs. But in the exam, you have to ask. That's your marks. Do you get the idea? So quickly, I will scan them. Do you get the idea? And of course, it's the most important part of the DDs for me here is what is this? Why? Because that's literally the order. You know what's happening with the patients, guys, the elderly, most of them, what will happen? They will have a stable angina. They don't take care of themselves. They become unstable. They don't care of themselves. They become MI. That's the order. Always in the elderly, especially people who are not having any risk factors or whatever. So they have stable angina in the beginning, they will be okay. Like you can take care of yourself and take medication and work on your lifestyle and so on, but they ignore it. They think it's nothing. Then it becomes unstable angina. Then it becomes heart attack, because unstable angina is a minor heart attack, so it becomes major heart attack now. They get the idea? Good. Therefore, I have to ask how to ask about those two, if I may ask you. What is the first question for the angina? Angina is what? Recurrent chest pain. Am I right? So that's the first question. So can I kindly ask you first of all, is that the first time you're having chest pain like this? That's number one. Is that the first time you are having chest pain like this? Yes, doctor. Okay, some of you will say now, okay, but he might be coming today unstable angina. Why not? Of course, it's highly likely. It's highly unlikely to be stable. Why? Because in front of you, he's resting. Why he's having pain? Because a stable should be in front of you fine, correct? Like resting with the rest, it will improve. So it could be unstable angina and he's coming for the first time, correct? Of course. So now I will ask, okay, Mr. Johnson, can I kindly ask you, is that the first time you're having such a pain like this? Yes, doctor, it's the first time it's happening to me. Okay, and do you feel this pain is always coming when you exercise or when you are doing any physical efforts or physical activity? No, doctor. Now I am done with that. Unstable and stable. Do you know what I mean? So do you feel this pain is coming whenever you are doing any physical activity or you are doing any effort or exercising or whatever? No, doctor. It just happened all of a sudden today. In which I have to ask him, by the way, today, okay, Mr. Johnson, when you had the pain today, what were you doing at that time? Because it might be unstable angina, happen with anything. Correct? Do you understand the 3 questions now? So number 1 is, now when I'm doing this, I'm scanning both stable and unstable angina. Number 1 is recurrent. Is that the first time you are having such a pain like this? No, doctor, it's not the first time. Sorry, yes, it's the first time. Okay, and do you feel this pain is coming whenever you exercise or whenever you, can you link it for physical activity or exercise or effort, physical effort? No, doctor. And Mr. Johnson, when you had the pain this morning, what were you doing at that time, Mr. Johnson? Did you say to you, by the way, doctor? Nothing. I was just reading some newspapers. That's it. Do you get the idea? Okay, this means what? Pain at rest. Okay, it could be correct, by the way, it could be MI, it could be unstable angina. I can't know. It's not me. It's not my job now. The job of what? Of the cardiac science and stuff. It's not me. Do you get the idea that I'm trying to do my best to reach what's happening? Do you get the idea? Now we are done. What will we go for now? Pericarditis. How to ask about pericarditis? Next, first all forward. Okay, Mr. Johnson, do you feel this pain will improve or is improving when you are leaning forward by any chance? No, doctor. Nothing is helping me at all. Do you feel this pain is improving when you're leaning forward? No, doctor. Now, do I need to ask what flu-like illness or whatever? No. Why? Because the pain started this morning. Do you get the idea? By the way, you might, if you want, it's okay, it's not wrong, but no need, but you can ask. So, Mr. Johnson, any recent flu-like illness or viral infection? No, thank you, I'm done with the pericarditis. Because it could be a reaction, yes, it could be a reaction from the heart. So you ask, do you feel the pain is improving when you are leaning forward? No, doctor. Any recent infection or flu-like illness, Mr. Johnson? No, doctor, I'm completely fine. Any trauma or chest trauma or injury, musculoskeletal pain? Any trauma, any chest injury, any fall on the chest? No, doctor. What is the last thing? Any rash? Correct?